Thanks very much for that. It's lovely to be back again today and talking to you about clinical trials and future therapies in PSC. These are my disclosures. I showed them yesterday, but just to mention that there are some trials that I'll be talking about, some drugs that are made by some of these companies, including Dr. Falk, Intercept Pharmaceuticals, Pliant as well. So occasionally these types of disclosures can cause a conflict for the person presenting. And so I'm just declaring that I have those conflicts of interest, although the money that I receive them for work that I do for them, I do put towards my research and not towards my own personal account. So today I'm going to briefly talk to you about how you can look up clinical trials online. I'm going to talk about the challenges of conducting a clinical trial in PSC. I'll be talking briefly about some current therapies for PSC and what the current evidence is from clinical trials, as well as future therapies and some trials in progress. Now, how can one look up clinical trials? Well, first of all, a couple of reputable sources would be Google Scholar, as opposed to just Google by itself, and PubMed. So Google Scholar looks at published articles rather than which have usually been peer reviewed, rather than just what any old Joe blogs can publish on the internet. So the believability and the integrity of the articles in both of these sources are much higher. And so what I would do is, if you know there's a study, for example, what happens is when I show you slides, I will have some references at the bottom, and you can just take the title, like what I've put here, and you can put that in verbatim, or you could put in the author and a few keywords, or you can use medical subject headings if you know them. So in PubMed, you can search for subject headings. So if you type in cholangitis and you click a bit on the side that says, and you're typing a mesh and you'd search for it, this is the mesh for PSC. There isn't a mesh for primary sclerosing cholangitis, just so you know. There are other forms of sclerosing cholangitis, such as secondary sclerosing cholangitis, but there's very few articles about them. There's also IgG4 sclerosing cholangitis, which occasionally there are articles about. Another thing you could do is, if you saw, for example, a slide I was giving today and you wanted to look up that trial, then here you can see the reference I've given. Generally, it will be the author, or sometimes it might be et al. So it'll just have the first one or two authors. I don't always include the title, and that varies. But then you'll normally have the name of the journal that it's in, British Medical Bulletin, and you'll have the year that it's published, and then you have the volume, and in brackets it might be an issue of that volume, because often, say 2015, all of the volumes are 114, but then they go from issue 1 to 12, and then it'll have the page that it's on. Some of these journals you do have to subscribe to, and depending on whether you have an affiliation with any university, you may not be able to access them, but I'll give you a hint soon. So you could also go onto the website of the journal rather than just using Google Scholar. So then there's ResearchGate, which is a bit like Facebook for academics. And so many of us academics, us researchers, have got author profiles. You can go and look up some of our research on that. And often we will put a full text of our article on here as well. If there isn't one and you see one, that you like, you can actually send the author a request for a text, and they may or may not respond with it. Another thing you can look up is clinicaltrials.gov, which is where, if you have a clinical trial of a new product or intervention in PSC, then you need to list it with this website. Even though it's US, it's still worldwide. One does that. And so when I typed in sclerosing cholangitis recently, I found there were 110 studies listed. And they're not all recruiting at the moment. Some of them are finished or about to start recruitment. But it's interesting, and it's a way that you can keep up to date with what studies are going on in PSC. So I had a quick look at how many trials with the term sclerosing cholangitis were published each year. So I haven't gone through them individually, but the majority probably are PSC. You can see from 2012 to 2021 that it's increasing, bit of a dip here with the pandemic, but there are a huge amount of trials here in 2021. So there are a lot of studies being published around PSC. So now, what are the challenges facing us when conducting a trial in PSC? Well, first of all, people with PSC, it's a heterogeneous population. So what do I mean by the term heterogeneous? So there's homogeneous, which means that everyone's very similar, and heterogeneous, which means there's a lot of variety amongst everyone. And this is clear because some patients with PSC do very well. Some patients with PSC have complications and can need a liver transplant. And there's lots of different clinical features. So it's not very uniform like some diseases. So that makes it a bit more difficult to study when the people you're studying are all quite different. It's a rare disease, so it's difficult to recruit people to a clinical trial and to recruit enough numbers. So therefore, because most hospitals don't have that many people with PSC, then you often need to have lots of different centres involved. And then that entails all sorts of problems that you're having trials conducted all over the world with lots of centres only contributing 2 or 3 patients, compared with studies where you can contribute, 20, 40 per centre. And then the other thing is it's a long duration until you get a clinical outcome. So the clinical outcome that we're interested in is slowing the progression of disease, slowing people needing liver transplants, slowing people dying from PSC. And you can't keep a trial going for 20 years to get a clinical outcome. So we have to use surrogate markers. So surrogate markers are things that you can measure which are not the outcome you're looking at itself, but can give you a prediction of that outcome. And I talked about some of these in my talk yesterday. The most common surrogate marker that we use is ALP, or alkaline phosphatase, which is a liver enzyme we measure in the blood, and it usually goes up in PSC. And we know that if it reduces to below 1.5 times the upper limit of normal, so below about 180 or so, then it's associated with a good prognosis. We also know that FibroScan, which is transient elastography, histology, which is the liver biopsy, and the bilirubin in the blood are also good prognostic markers. And these were discussed in this position paper from the International PSC Study Group, who met with the FDA, the Food Drug Administration, who are in America, who are the people that decide what drugs get licensed. And so therefore, a lot of trials are based on what the FDA recommends. So the FDA and the International PSC Study Group met and went through all the literature and research, and none of them thought that they exceeded a really good validation to say, yes, this marker is the best marker to use. But they came up with some advice, and they often talk about composite endpoints. So instead of just giving a drug and then we base it on what happens to the ALP, or we base it on what happens to the elastography, they often talk about a composite endpoint where you have both a reduction in one thing and another, and that's your outcome. So I hope I haven't confused you too much, but the main point of this slide is to say that there are many challenges in designing and carrying out a clinical trial. So some of the current therapies, some of you who have PSC may or may not be on ursodeoxycholic acid, and one of the brands we use is Ursofolk. And this is a list of all of the, I think it's 13 or 14 studies that have been done looking at urso in PSC at different doses. It's a weight-based dosing. This is to do with the design of the trial, but if it's PC, it means there was a placebo involved, which are the best type, that there's placebo involved. And here it shows the number of people on urso versus the number of people on placebo. And they're small numbers. They're all below 100 in each group, except for 101. And you can see that the number of months they went for, the longest was 5 years. And they almost all showed that the liver biochemistry, which is the ALP, improved. And, in some cases there was symptomatic improvement. So this one was the landmark early trial from the late 90s that showed that the ALP went down compared with placebo. However, then there was this study by Olson, which showed that at a dose of 17 to 23 milligrams per kilogram per day, that you could have better outcomes. It showed that the ALP went down, but it wasn't able to show that it reduced people dying from the PSC or needing liver transplant. But it did show up, but it wasn't statistically significant. So in other words, they aimed to recruit 346 patients, but they only recruited 260. And so they weren't able to quite prove that urso works the way they want it to work and prevent death, etc., but probably because they didn't have enough numbers. So when we say there's no conclusive evidence for urso showing that it improves your outcomes, it's probably because of the difficulty in conducting trials and the fact you need very large numbers and you can't achieve that. But I must just give you a word of caution that this last trial that was done in 2009, which is a very well done trial, actually showed that there was a higher rate of people deteriorating when they're on URSO compared to placebo. It was very high doses. It's double the dose we use in another liver disease called PBC, which is what it's actually licensed for, this drug. So I think the main thing to say is that we should be careful with how we use URSO, not use it at too high doses. We don't have conclusive evidence that it reduces the risk of dying or needing liver transplant. But this is a really good pro forma that I use. If your ALP is up, that's ALK is ALP, then you could discuss with the patient about using it. And at the dose of that study that was in the yellow box that suggested possible benefit. And then you just give a 6-month trial. And you have to check the patient's monitoring it. And you have to check that their ALP actually comes down. And if it does come down, then maybe they should continue on it. But if it doesn't, then probably don't stay on URSO. So that's what my take is on URSO, but you will find that different specialists say different things. And the other issue with URSO is that it's not licensed for PSC. It's only licensed for a different liver condition. And so if a doctor gives you URSO for it, it's not really covered by the PBS, although it may be used off-label, and I'll let you talk to your specialist about that. So immune suppressive therapies are used in inflammatory bowel disease, and it's PSC is a problem with overactivity of the immune system. So what about some of these immune suppressing tablets that we use in inflammatory bowel disease and we use in autoimmune hepatitis? Things like azithromycin, cyclosporin, methotrexate, and tacrolimus. You may have heard of some of them, but it doesn't matter, but they're all drugs which can suppress your immune system. So look at the studies that have been done. They're only in up to 20 people. They're very small studies. Most of them are not PC, placebo-controlled trials, where they have the placebo. They're mostly just they give the drug and see if it works. And so a really robust study is best if it's done against a placebo. So you know that it's the drug working, and you know what would happen if you didn't give it, if it's the placebo group. And the only one that really persistently showed improvement in the liver tests was tacrolimus, which is a drug we actually give people for liver transplant. But actually, a large proportion of patients couldn't tolerate the tacrolimus. It was something like 1/2 to 2/3. So it's not actually something we give because there just wasn't conclusive evidence. It was open label, not placebo-controlled trial. But just to say that these drugs, we've got limited data, and so far none of them have shown being proven that we should use them. There's been no studies or randomized controlled trials of steroids in PSC. There was one study where they added in with this anti-inflammatory drug they use in gout called colchicine versus placebo. It was only 12 patients, and they didn't find improvement in the liver function tests. And there is a few conditions where steroids like prednisolone can be helpful, such as when you have autoimmune hepatitis as well as PSC, or if you have high IgG4 levels. This is probably an area for another talk. So one more study I want to talk about was if you have a dominant stricture, a narrowing of the bile duct that is significantly narrow. So everyone's got, with PSC, has narrowing of the bile ducts, but a dominant stricture is a very, very narrow one that's more prominent that about 10 to 50% of people with PSC get. So this study, if you had a dominant stricture and you needed to have it dilated, which sometimes happens, and they do that endoscopically, they either dilated it with a balloon, the bile duct stricture, or they dilate it with balloon and they put a stent in. And a stent is a cylindrical tube which holds the bile duct open. And this, so just ignore the dotted lines. The black line is people who had stenting, and the grey line is the people who only had the balloon. So both of them had a balloon, but one also had a stent left inside the bile duct. And this is their survival over time. And there was no difference in patients' survival or needing liver transplant, whether they got a stent or not. However, if you look at the serious adverse events related to the procedure, that's what SA is, then the people who were in the balloon dilatation group, 6.7% had a serious adverse event versus 45% who got a stent. And a lot of them were due to inflammation of the gallbladder and the pancreas. So this study clearly showed that there was no benefit of putting a stent in at the same time, and also that you actually have higher side effects. There are a few situations when you might use a stent, but in general, we don't use stents for dominant strictures. So this is a good example of a clinical trial looking at the way we manage something that happens in PSC, and it helped guide the way we do manage it. Itching therapies. Some people with PSC have issues with itching, and there's really very few data. Pruritus is another word for itching in PSC. And so there's another disease called primary biliary cholangitis, a completely separate disease from PSC, but it affects the bile ducts, and people itch in that disease. And so most of the recommendations are actually from trials in PBC. The exact mechanism of the itch and the pruritogen, which is the thing that causes the itch, is unclear. It's unclear whether it's bile acids or something called autotaxin. But these are the therapies that we try. Cholestyramine is a sachet which can work in about 20% of people. Rifampicin is an antibiotic that actually is quite beneficial and can help with itch. There's a few other therapies with no randomized trials, but a little bit of data. There's this drug called bezafibrate, and the FITCH trial did look at PSC patients as well as PBC patients, and it showed a significant reduction in itch in patients, and it may also have an effect on the liver tests in PSC. Now, this drug is not available in Australia. There's a similar drug called fenofibrate, and it's a cholesterol-lowering medication. It's now being shown to have some benefit in some bile duct liver diseases. So I think this is a watch this space, but just to mention, there is a good itch trial in PSC, but the drug's not available here. It's a tablet. And sometimes there's very good data to show that if you have a liver transplant, if you cannot stop itching when you have PSC, a liver transplant will take the itch away. So the final thing I want to talk about in terms of clinical studies is liver transplantation. So if you have advanced PSC, where you have cirrhosis and the liver's starting to fail, then it may be that you need a liver transplant. And in general, we use something called the MELD criteria, the model for end-stage liver disease, which inputs some blood tests and various parameters, and it gives us the likelihood of someone dying from their liver disease. And we use this when people have end-stage liver disease. So generally, people are referred for a liver transplant when their MELD is higher than 15. So the higher your score, the higher risk your liver disease. The only thing is that bilirubin is a component of the MELD score, and people with PSC can have not very advanced liver disease, but their bilirubin can be raised because of poor bile flow through its strictures. So sometimes the MELD has to be adjusted for what cutoff they will use to refer people for liver transplant. And they also will accept people with a low MELD score, but who have very bad itching. But the studies looking at the European Liver Transplant Registry show that if you get a liver transplant for PSC, your survival is excellent. These survival figures are actually very good for a liver transplant. You may get recurrence of the PSC in the liver transplant graft, and these are some of the factors that have been shown to be associated with getting a recurrence. But it's not a reason not to give someone a liver transplant, and you can deal with that if that happens. So now I'm going to talk about future therapies. So norursodeoxycholic acid is similar to ursodeoxycholic acid. This is urso, the one you're aware of, and it basically has one less side chain. So this is the chemical structure. And just to say that it's got multiple mechanisms. This is a bile duct. It's got some anti-inflammatory, anti-scarring, anti-proliferative, which means proliferation of bile ducts and liver cells, and also may detoxify some toxic bile acids. And through all of these strategies, it's thought to potentially have a role in PSC in the liver. So I just want to take you through this mouse study paper. So WT is wild type. So this is a mouse. This is a liver biopsy of a mouse. And here's the bile duct, which is normal. The red is scar tissue, and this is just looking at the individual cells. So this is a normal liver in a mouse. And then when you knock out a certain gene, you get scarring around the bile ducts. You can see this red and this purple around the bile ducts compared with not being there here. So this is a mouse model of PSC where they can knock out a gene and they can imitate PSC in the mouse. This is still in the liver. So then they give that mouse who's got the PSC urso or ursodeoxycholic acid, and it reduces scarring, but there's still some scarring there. But then when you give norursodeoxycholic acid, the drug I'm talking about, it looks amazing. All of this scarring here in the triangle has gone away, and it looks very similar to the mouse without any PSC. So these were the initial studies in mice of this drug, and they went on to study this drug in humans with PSC. And so they had 4 different groups. Patients either got a placebo or 3 different increasing doses of NOROSO. So they were in one of these groups. And they got it for 3 months or 12 weeks, and then he stopped. And so they found that at 12 weeks, the people on placebo had no change in the ALP, or went up by about 1.5%, whereas with an increasing doses of the norosodialkylcholic acid, you have greater reductions in your ALP, which if you came to my talk yesterday, you know is a good prognostic thing for your ALP to go down. So phase 3 trials are now ongoing. Another prognostic marker I mentioned yesterday is that if your ALP goes below 1.5 times the upper limit of normal, it's a very good prognostic factor. You're less likely to progress to advanced PSC. And actually, 12-13% of people on placebo on the low dose of the NOROSO reach this good outcome. So even with a natural history, you can sometimes reach this outcome. But a vast majority of people on the higher doses, the intermediate and higher doses, actually reach this outcome. So some good data from this phase 2 study, and it's now going on to larger phase 3 studies. So now the anti-integrin against alpha V. So an integrin is something that is on a cell, and it can signal to other, so the cells may be in your liver, or they may be on blood cells, and an integrin will go and attach to certain other proteins. And if that integrin is activated, it can bring about certain processes to occur. So this drug that I'm going to talk about targets alpha V beta 6 and alpha V beta 1. So it's against alpha V. So the drug will target alpha V, and by doing so, it will block the processes of this integrin. Now, what does this integrin do? It's highly expressed on cholangiocytes, which are bile duct cells, which we know are involved in PSC. And it's also highly expressed on fibroblasts, which are cells which bring about scarring in the liver. So the drug that I'm going to talk to you about targets the bile duct cells and scar-making cells. And so if you block both of these proteins, then it may help us block TGF-beta, which is a scar-forming inflammatory cell in the bile duct. So the drug is called PLN 74809. It's made by Pliant Pharmaceuticals, and it's an oral drug, and it inhibits these potentially scar-forming pathways. So this is this mouse model I said before. So this is the mouse with some scarring around their bile duct, and the red is the scar tissue. You can see less red with increasing amounts of the drug, so less scar tissue in the liver. And this is looking at the liver enzymes of these mice, where mice who didn't get the drug had their ALP up around 400, and with increasing doses of the drug, they had lower liver enzymes. So there's a phase 2A clinical trial right now called Integris PSC, which is recruiting patients with PSC, but it's not all patients. You do have to have a little bit of scarring for this drug, and that's measured by a blood test or a FibroScan. So I know this is present in a lot of states around Australia. We have it in Adelaide. There's some states in the eastern states, and I think WA might. But you can also look up this on clinicaltrials.gov to see what centres are recruiting. So FXR, farnesoid X receptor, is a receptor that's present in the liver as well as at the end of the small bowel. And if that receptor is activated, it can regulate bile acid metabolism and formation, which is important in PSC, and it can also affect scar formation, which is called fibrosis, and it's also present in the bile duct cells, so bile duct cells, liver cells, and in the small bowel cells. And we know that if you activate this receptor, it can help in certain liver diseases, including PBC and other bile duct disease. So there's a couple of agents which agonists means that you stimulate the receptor. There are a couple of agents called obeticholic acid and CILOFEXOR, which is a Gilead drug, and these are both drugs which that are being looked at in PSC. So this is the ESOP study, which is obeticholic acid, and they looked at week 12 and week 24 in both patients who are on URSO to start with and not on URSO to start with. So maybe if I go to patients who are not on URSO, you can see that the placebo group had a drop in their ALP by about 5 and 7% at week 12 and 14, but the patients on the 2 doses of the drug, obeticholic acid, had much higher drops, so their ALP dropped further. And then the other study, CILOFEXOR, Again, we're looking at the ALP drop at week 12. So there was an ALP rise in the patients who were on placebo versus a drop in those on CILOFEXOR, particularly the larger dose. And then they separate it out into those who were on URSO at the beginning or not on URSO. So the phase 3 clinical trial of CILOFEXOR currently recruiting here in Australia. I think there is a phase 3 obeticholic acid trial, but I think it's in North America. I'm not sure it's actively running right now, but it's not in Australia. So the last thing I wanted to mention about possible future therapies, and I think this has been done in the eastern states occasionally, is when you get a cholangiocarcinoma with PSC. So this cholangiocarcinoma is a cancer of the bile ducts, as seen by these cells here. And you can either get it right in the bile ducts within the liver or ones outside the liver. And so the ones that we're talking about are perihilar, which is the ones by the hilum, which is where it exits the liver, the bile ducts. So it's this when the cancer is located here. And sometimes when you get these cholangiocarcinomas, they can be resected and operated on. But if it's not thought to be able to be resected and have an operation, which happens a lot of the time, then they had 12 US transplant centres who looked at people with these perihilar unresectable cancers, and they then gave them what's called neoadjuvant chemoradiotherapy. So the term neoadjuvant means before any type of operation, and they gave them chemotherapy and radiotherapy during this time. And they had 287 patients, and 2/3 had PSC, and they followed them up. And they then put them on to have a liver transplant. So usually if you have this cancer, you can't have a liver transplant. But they suggested that you could give this therapy, the chemo and radiotherapy, and then have a liver transplant. So of the 200 and something odd, a proportion of them were able to go and receive a liver transplant. And actually, they did very well. Now, I know I said here that 22% died. However, that is a much better prognosis than if you had had nothing done. So usually there's limited options for cholangiocarcinoma, whereas here in this select group of patients, they were able to have a liver transplant after chemoradiotherapy, and only 80% came to a bad outcome. So this is an exciting study. It's not something done widely around the world, but I just mention it as a potential therapy for those with that type of cholangiocarcinoma. So in conclusion, there are more trials than ever before in PSC, with 110 on clinicaltrials.gov. You can look up clinical trials, and I think you remember there are over 200 published in 2021. You can look up clinical trials easily, and I mentioned some of those places you can go and about the medical subject heading term. Current therapies, there's mixed and limited evidence. I think there is some evidence for certain therapies we use, but we're still looking for the holy grail for what we can give people with PSC besides liver transplant. Liver transplant does have very good results for those who need it, but not everyone will need a liver transplant. And there are lots of different mechanisms of action of drugs being trialled. I've never seen so many drugs being trialled in PSC. And I mean, I know that I've been researching PSC since about 2012, so only 10 years. However, I have read as best I can, I've read all the literature to date. And really the only studies that were going on before the last 5 years were the ursodeoxycholic acid and those immune suppressants, with very small studies. But it's so exciting that there are multiple agents with different mechanisms of action being trialled in large amounts of people with PSC. And so I haven't talked about all of them here today, and I've definitely not talked about ones that manipulate the gut microbiome, because Associate Professor Palak Trivedi from Birmingham will be talking about that. But I hope that you've learned a little bit about how we use clinical trials and what the evidence is for current and future therapies. And I would welcome any questions. Thank you very much.